So without further ado, I'm going to invite Austin to introduce the next speaker while I put up the slides. Is that still the plan? Thank you so much. And Austin opened up the first Leon workshop as well as every workshop, I think. So he was there with the bake.
Thank you very much, Antonia. The lasting quote I got out of Chris Redman was, and I don't know whether this was his original quote or he adapted it, but he said it to me, Austin, measure everything that can be measured and make everything that cannot be measured measurable. So, yeah, I do have some memories of my own of the man. So Antonia and I agonized about who to ask to give Chris Redman's inaugural memorial lecture. And we considered names after names, authorities after authorities, and came down to the speaker today, who is Emeritus Professor Sabaratnam Arulkumaran. That's how you say it. Okay. And Arul, as everybody knows him, retired from St. George's University Hospital in 2013 as chair and head of the Department of Obstetrics and Gynecology. I don't think he understands the concept of retirement. Because my observation has been he has been busier since he retired than he was before he retired. And I almost think the man lives in airport lounges. He's all over the place. But since he retired, he's also become visiting professor of Institute of Global Health Innovation at Imperial College in London. And also foundation professor of obstetrics and gynecology, University of Nicosia in Cyprus. It's impossible to tell you all of his accomplishments, otherwise we'll be here till Christmas. So I'm not going to attempt to do that. What I will draw out is some of the key landing points in terms of Arul's career. He's led many of the important regulatory organizations in our specialty. So he was treasurer, secretary general, and ultimately president of FIGO, so the International Federation of Obstetrics and Gynecology. He was also president of the British Medical Association, and not least, ex-president of the Royal College of Obstetricians and Gynecologists. So the man has extensive leadership experience and skill. It's tough enough to get a national award in one country. But Arul has national award in 3 different countries distributed across 3 continents. So he was knighted by the late Queen in 2009 for his services to medicine, which is why today we know him as Professor Sabaratnam Arulkumaran. Got it? In addition to that, he was given a national Ranjanan award from his native homeland, Sri Lanka. And in Cyprus, he's also received a national recognition in 2019. But having said all that, the one thing that stands out for me is how Arul treats people and how he relates to people. For me, that's what stands out. And just to illustrate that point, he was meant to be in New York as we speak at a board meeting yesterday, today, and tomorrow. When we approached him to give this memorial lecture, he said to us, I'm going to be away, but if it's okay with you, I'll do it online via video conferencing. A day or 2 after that conversation, he contacted us to say, I'll come to Oxford in respect and recognition of Chris Redman. And I'll do the New York board meeting online. Ladies and gentlemen, Professor Sir Arulkumaran.
Microphones work, but are a bit far. I think this one will be. Do you prefer that one or this one?
This one is good.
I'm trying to put it in your. Can I touch it? Oh, sure.
Thank you. Thank you. Good morning, or just 1 minute to be good afternoon. So thank you, Antonia and Austin, for asking me to come and talk. Can you all hear me at the back? Yeah, thank you. It's nice to see so many people here and also some recognized people, especially Barry Schifrin, my old friend, who has come all the way from the States. So when Austin and Antonia really asked me to come or give a talk, first I said I'll give it by Zoom, as he said, because I was attending the Guttmacher board meeting in New York, which I had to do this afternoon because of the time difference. Because
just make it closer or hold this one. You keep this one, but maybe hold if okay. They're not
Hello?
easy to hold. I'll just move it higher up. Yeah, I'll switch it up. But I would rather just move this one up because this one is difficult to hold. It doesn't really work.
I can hold this one.
Can you just...
You can hold this one.
I think the holding is not perfect for anything. You can move it higher up. Sorry. Then you can still hold this one and see how we do. Thank you so much.
Seems very complex now. I don't know which microphone I should talk to. Well, I changed my mind for one reason, because Chris Redman, I have known him for a number of years, but more than anything, I thought he has left a legacy in terms of caring for the mother and children or newborns. When I say legacy, what do you really define legacy is difficult because people have different meanings. Legacy is a benefit to the current generation and the future generations to come. And that's what I'm going to talk about, the care for mothers and babies, his life history, but how he developed ideas and how he proceeded, and some of the ideas he thought he couldn't, but left the data behind for other people to work. And it boils down to 3D, data, digital, and devices, how you can incorporate these 3Ds to improve the care of the mother and the baby. So it's about his legacy, about his 3D ideas, and how we can work on that. So the objectives of my talk is to say that he was particularly interested in hypertensive disease in pregnancy. So I want to just give some idea about hypertensive disease, how it affects the baby and the mother, the magnitude, and also how he can intervene and reduce this morbidity and mortality. And specific contribution by Chris Redman. And finally, to what he would have done using the data he has collected over many years, as was suggested in the last talks. He has collected a lot of information which can be put into use. So this is urology which came in the British Journal of ONG by Professor Aris Papageorgiou and Manu Vatish, who are professors in Oxford. And the first paragraph on the right-hand side is about his research, groundbreaking research in the mothers. And the bottom paragraph is about his work with Jeffrey Dawes about the Dawes-Redman criteria or the system. The first one is actually, at his time when he started working, there were no drugs used to bring down the hypertension in mothers because they thought it is masking the disease and we should really measure the blood pressure and keep going unless the blood pressure is too high, without understanding the hidden dangers of just continuing with the high blood pressure, which I'll illustrate in a minute. And the second thing is actually the drugs were very rarely used in pregnancy because people thought it might give rise to problems. So he's the first one to introduce in this country antihypertensives, methyl dopa for hypertensive disease in pregnancy, and showed that it has no ill effects on the mother or the baby. So I'm going to expand on those two concepts, on the mother and the baby, which he was doing. Now, coming to the magnitude of the problem, these are the figures in 2023, I think. And globally, 76,000 women die each year from preeclampsia. So it's a big magnitude. So it's an important area to research into. And there was a preeclampsia summit this year by the WHO just a few months ago in Kigali because it was a major problem. And 500,000 babies die globally because of preeclampsia. That's now. So when he started practice, it must have been a massive number. And the second thing is actually the regions where there are high maternal deaths due to preeclampsia are the same regions where there is deaths due to cardiovascular disease of women. Usually if a woman has preterm birth or preeclampsia in pregnancy, her life is shortened by about 10 years unless you take care of them. And not only their life is shortened, if you think about life expectancy in the UK for males are about 79 and females are about 83. Life expectancy is one thing, but healthy life expectancy, that means the healthy life expectancy in the last 4 to 6 years goes down. They are dependent. So if they get a cardiovascular accident like stroke or heart disease, they are in cardiac failure, they go to hospital so often because of the problems. So his concern was about that as well, which he was trying to work in the latter part of his time. So when we talk about cardiovascular disease, as you could see from this figure, the same countries and regions where there is high deaths due to preeclampsia are the very same countries where you have high incidence of cardiovascular disease in women. And if you take it into a number, 35% of all deaths in women worldwide are caused by cardiovascular disease. And 275 million women are diagnosed and 8.9 million die because of cardiovascular disease. And this is a modifiable thing. And the Lancet series mentioned it is understudied, under-recognized, under-diagnosed, and under-treated. And he was trying to collect data to see how we can explore and extend the lifespan of the women, not only their total lifespan, but also the healthy life expectancy in some ways. Now, this is just a graphical form. If a woman delivers from the time of delivery, the normal woman would by 25 years, the life expectancy has gone down by about 5 to 10%. But if they have preeclampsia, especially preterm delivery, then it rapidly declines. So what can we do to prevent these premature deaths in women on the long term? So his research interest, he knew from the very beginning, was about the mother and the babies. This is with Princess Diana in Oxford, talking about mothers and babies. And his concern was if you intervene early because of the preeclamptic disease, the babies are born very preterm and they die or have neurological handicap. So how can we increase the length of pregnancy? On the other hand, if you wait till late, the baby can die. And the late intervention means maternal morbidity also is high because suddenly they go into liver failure or HELP syndrome and so forth. So it's a delicate balance. So he was trying to work on both. One, on trying to prevent mothers dying in pregnancy due to preeclampsia and babies dying of preeclampsia. So his papers were very seminal papers, as I mentioned to you earlier on. On the mother's side, he did some good work on antihypertensives and trying to reduce the blood pressure, which affects the heart function for a long time, stresses the heart, and also on the antepartum non-stress testing with Jeffrey Dawes to see how we can continue the pregnancy without the babies dying. So these are classic papers, and a number of people have worked with him. And the objective analysis, as Austin said, he was obsessed about measurement all the time. And he put 10 different criteria, and they defined the clinical utility and the validity of limits, and it cannot be used in labor. Interestingly, I was working in Singapore at that time. They developed this Dawes-Redman criteria because we had 25,000 births in 1 year in one hospital. So one Roy Norum, which Austin will know, he brought the machine for us to do the work. And I thought it might be better to do it on admission so that we can pick up the difficult cases. And I sent my report, and Dawes got me on the phone and really gave me a proper blackguarding for doing that in labor, because he said it's not meant to be in labor, so why did you do that? But anyway, they did a good work with the numbers which are coming. And following the original work, there were a number of papers by others validating their work. And I just want you to pay attention to the first one, because the first one, the validity of Dawes-Redman criteria can be measured in 10 minutes, 12 minutes, or it might take up to 60 minutes. And the second one, it is not met. And interestingly, it is giving in the comments high probability of fetal anemia, because it thinks the variability is a sinusoidal-like pattern. And that was the case. So the machine can detect even what we can, on eyeballing, I wouldn't say it's a sinusoidal. I might have confused that with a variability. So the machines they produce was able to do that. Not only their publications, but also they promoted multi-center research, which you would know about Truffle 1 and Truffle 2 studies, comparing computerized CTG with ductus venosus flow in areas of 28 to 32 weeks, the difficulty in decision-making, pregnancy area, so that they can give you some idea when is the right time to intervene. And the computerized CTG withstood the test, comparing it with the ductus venosus. And there was a 2-year follow-up, published by Christoph Lees and his co-workers. And that also showed the results are almost equal, although the ductus venosus flow was slightly better, but they had more peripartum deaths. So when we cancel both out, then one can use the one or the other. The major advantage is for ductus venosus flow, you need somebody with expertise and the machines, whereas with the cardiotocograph, then somebody can do it without much effort. Now about the maternal, I'm just showing him with Jim Roberts, who was a giant in hypertensive disease in the United States, and Sanjeev Gutte from India, who was Secretary General of Gestosis organization. I put one paper I wrote with Jim Roberts and Joseph Villa, because we are thinking about whether to treat eclampsia or not, or to prevent eclampsia, should we be treating or not. Because Chris Redman had a different view that maybe we should not treat. And then he changed his mind after some time. And I put an editorial in the Singapore Journal at that time saying that the obstetricians should change their lenses, not only just looking at hypertensive disease and after delivering walk off saying I had done my job, because if you do cesarean sections, the babies had a number of problems, increased gastrointestinal disease, asthma, allergic rhinitis, and so on, because it affects the gut microbe. And the mother, she has premature hypertensive disease, cerebrovascular disease, kidney disease, thromboembolism, and many other things. So it is quite a difficult strategy to manage unless you have a plan how to manage these mothers during pregnancy, before pregnancy, and after pregnancy to reduce these adverse incidents, both for the baby and the mother. So I put a list of 6 items which was crossing our minds when we were talking about. One is to check the blood pressure prenatally and to control the blood pressure. People with polycystic ovarian syndrome, people with some obesity, metabolic syndrome, or diabetes, and control that before they get pregnant. Number 2 is to screen using biomarkers as well as uterine artery Dopplers and find out who is likely to get hypertensive disease and give them low-dose aspirin to prevent preterm preeclampsia. Number 3 is actually maternal treatment of blood pressure control, which was Chris Redman's original work, so that the heart is not pumping for a longer duration against resistance and the heart might get damaged. Number 4 is to monitor the baby to find the optimal time of delivery so that you don't stress the heart of the mother for a long time, and also you don't wait for neurological handicap to happen. Number 5 is actually, it is known now, the 4th trimester is a dangerous period, because once she delivers, there's a 40 to 50% increase in blood volume, and the mother has to pump this, and the incidence of hypertension is much higher in this, and we have to treat them early so that they won't get hypertensive disease in the long run. And finally, have a long-term regular follow-up with a general practitioner so that when they develop hypertensive disease, it can be done. So these are the 6 items which we thought we should explore. Because the main reason we think preeclampsia is occurring, earlier we used to think there is insufficient uterine vessel penetration by the trophoblast. Now we know that is also true, but also the heart of the individual woman is not adapted to pump more than 40 to 50% of blood volume. And that stress is the one which is causing preeclampsia. Now in the past we used to do uterine artery Dopplers, doing a notch in the uterine artery, but now you can do it even in an ophthalmic artery because it's a systemic resistance in the whole body, not particularly in the uterus, and you can give them antihypertensive drugs or aspirin and reduce the incidence of developing preterm preeclampsia. So this is the pictures of the maternal heart. If you look at mothers with severe preeclampsia, nearly 30 to 40% will have something or other there, especially if it is preterm preeclampsia, then they have much higher incidence. We put 20% at a minimum. And so we believe strongly that ductus venosus flow or computerized CTG might be efficient so that we don't expose the mother for a long time with this cardiac strain, but also we monitor the baby so that we deliver at the optimal time and don't expose the mother and the baby to stress of hypoxia. Now I mentioned about the 4th trimester or the soon after delivery. This is actually looking at the cumulative incidence of getting antihypertensive treatment and time of delivery in months. And as you could see, at the initial period, within the first 3 months, or in fact the first 42 days, many of those mothers who had hypertensive disease go on prescription for antihypertensives. Nearly 40% get prescription if they have preeclampsia in the preterm period. But if it is preeclampsia with severe features, no outpatient antenatal treatment, they get 20%. So the hard indices who are likely to develop preeclampsia, hypertension after preeclampsia, is those who have antenatal risk factors, those who have blood pressure tablets for hypertension even before they got pregnant or during pregnancy because they can't handle big cardiac load. So you can subdivide them into different types of preeclampsia, preeclampsia at term, preeclampsia at preterm. All of them had the spike at the first 4 weeks. So first 4 weeks are quite important. And by 4 weeks, then the blood volume settles and then she has less strain on the heart and the blood pressure comes down. So in a summary form, before the delivery or antenatal care, you have to think about gestational diabetes, preterm birth, hypertensive disorders. All that can give rise to problems and cardiovascular disease. And they are common endothelial dysfunction, inflammation, and insulin resistance. And Chris Redman did a lot of work on inflammatory response in preeclampsia. And on the long run, they end up in cardiovascular disease like heart failure, stroke, kidney disease. So not only they have premature deaths by 10 years, but also the healthy life expectancy is cut down in those people. And on the long term, we have to partner with general practitioners and engage them in measuring the blood pressure of women so that they don't run into problems. So it's multilingual communication may be necessary in a multi-cultural society so that each and every woman who has preeclampsia is looked after for life. Now coming to the fetal morbidity, not only it stopped with the antepartum, but also intrapartum morbidity and mortality in labor. So Chris devolved into intrapartum CTG computer analysis. That's what Antonia's work is doing now. I'm just going to illustrate that the difficulty we have. Of course, I had to admit I learned a lot from Barry Schifrin and acknowledge him, and I worked with Richard Paul. He worked in the same unit, Hond and Paul, in 1985. So when we talk to interpretation, we talk about FIGO, nice guidelines, physiological guidelines, but essentially we are correlating with clinical situation. Without correlating, you can't come to a conclusion what to do. Now sometimes we think we are interpreting according to FIGO or physiological, but sometimes it's pattern recognition because those are very peculiar patterns which I'm going to show you. And incorporation of risk factors and appropriation of action has to be timely, because sometimes you recognize the problem, and if you don't act on it, then you can blame the method, but it has nothing to do with the method or the action. And it may be that the rate of development can be predicted by computer-assisted artificial intelligence analysis on the long run. So I'm going to show you some interesting things. The first lesson I had in Los Angeles was there are two accelerations. The trace is reactive. So I asked Dick, what do you mean by reactive? He said, because fetal movements and the baby reacting to the movements, and there are accelerations. And if there are no decelerations, then there is no stress of hypoxia. So in a trace, if there is no deceleration, then there's no stress of hypoxic contractions. So this baby has good accelerations, good variability, no decelerations, they're doing well. And same work was done in the UK by Richard Beard, who said that if the accelerations are present, then not a single baby is acidotic, but with all the complicated patterns, the more features becoming abnormal, the greater the chance of acidosis. But timing of it is the difficult thing, when to intervene. So this is the FIGO guidelines, which many people follow globally, and it encompasses things like sinusoidal pattern, increased variability, prolonged deceleration, and with the high probability of hypoxia, these things do happen. Now, teaching over from 1985 onwards, few things I learned which we put into action. Jeffrey Dawes at Redman described the active sleep pattern, and there was some work in Netherlands and Denmark on looking at this very carefully. I can see the active and sleep segment alternating, and we call it cyclicity, and that is the concept of reactivity and cyclicity. That means the baby is healthy and has no hypoxia. So keeping that as a concept, Barry and I was asked to give evidence in a medical legal case, and this is an obstetrician, very experienced, did a one-tooth delivery, and the baby came out with reasonable APGAR, and then the baby was jittery and fitting, and they did a lumbar puncture thinking it might be infection, but it was blood stained likewise. So they said the obstetrician had done the damage and put in the vacuum and pulling. There was no cephalohematoma, nothing. So we looked at the trace, and it shows sporadic acceleration but no cyclicity. So we said something else before she even came into labor, something has happened. So maybe a vascular accident, and they had to investigate. And that case was pushed out, as you could know, Barry. This case.
Sorry.
This case, you can remember?
Absolutely.
Okay. So they did an investigation and found there was Singapore, yes, vascular injury. So this type of thing, if something can prompt out, not everybody might pick it up, even though they know the basic concept. Now, Myers, as you could see from the paper, Ronald Myers, tried to show the speed with which acidosis develops. Now, that is something which is difficult for manual interpretation, except for very few typical cases. Now, in his cases with the monkey experiments, he said total asphyxia causes change to brainstem, thalamus, hypothalamus, and it gives rise to appetite, cerebral palsy, prolonged hypoxia with acidosis, brain swelling, cortical necrosis, and quadriplegia. And if it is acidosis, without acidosis, it's white matter damage. And total asphyxia followed by prolonged deceleration, then it will be both the thalamus, hypothalamus, and the cortical aspect will be damaged. Now, based on that, we had to do the CTG interpretation. And my submission is that some CTG are recognized by familiarity and without clear pathophysiological explanation, like sinusoidal, thinking it's anemia. It can be physiological sinusoidal. Chain strokes with abruption, and very people can recognize the chain strokes pattern. And the other things is sudden rise in baseline. Suddenly if it jumps and has a different baseline by 20 beats and become flat trace, then it could be a cerebrovascular accident. So those things are difficult for hundreds and thousands of obstetricians and midwives to recognize. So if it can be fed into a computer system, that would be worthwhile. So, and we also find it difficult to find the progression of the depth and duration of deceleration. And some work from New Zealand shows that if the duration and the depth is increasing in an animal experiment setup, the deceleration is not only due to chemoreceptor, but also due to myocardial hypoxia. So how can we quantify that? Ola Shield, one of the doctors from Ireland, did a PhD here in Oxford and looking at dip areas. And we don't look at interdeceleration intervals. It is not in any other classifications. But if the decelerations get prolonged, the interdeceleration interval getting shorter. So it's going to be very shorter time at the baseline. So putting all these things together, we can talk about chronic fetal hypoxia. That means the baby is already hypoxic. This is a paper by Jeffrey Phelan, who also worked in the same group in Los Angeles. And he showed about 33 neurologically handicapped babies, except 4, 28 had, or 29 had the same pattern, which shows chronic hypoxia, no reactivity, no variability, and hardly any variability with shudder decelerations, which are less than 15 beats, which is normally the definition threshold. So that is become recognized, but this pattern can be also due to other factors like infection and meconium and so forth. Acute fetal bradycardia is well recognized because if it becomes 80 beats, it will have 800 circulations. If it is 140 beats, 1,400. So the lower the baseline and greater the length, it will become more acidotic. So the first paper which we did was in Singapore, looking at the effect of fetal pH. And we got ethical committee approval to do, when there was bradycardia, to keep on doing pHs because there were only two operating theaters for 25,000 deliveries. And there was something going on and we couldn't do anything. So we gave terbutaline to abolish contractions and kept on doing and written this paper. And we showed that. And 25 years later, T.Y. Leung from Hong Kong also showed the degree of drop with acute bradycardia, 0.01 every minute. That was the paper. And we said if the bradycardia goes up to 4 minutes, the acidosis becomes greater. If there is absent variability, if the heart rate is less than 80. So we coined the 3, 6, 9, and 12 minutes guidance, so as to speak. And it has become embedded in all the literature, but nobody shows a reference, except I can show you from our books from 1985 that we recommended that. And Dick Paul and his unit did a paper on rupture of cesarean section scar and bradycardia, and they said about 23 minutes and the baby gets severely acidotic. So that is how it looked like with bradycardia. And the third pattern we say is subacute, so where it's like a baby swimming, and if you dump the baby for 2-3 minutes under the water, keep the baby 30 seconds on the surface and dump it again, then the baby is going to get hypoxic and acidotic sooner. But if you keep it all the time below water for 8 minutes, the baby is going to be acidotic. But if you get it irregularly and with closing of interdeceleration space, there will be catecholamine surge, heart rate goes up. So the patterns will vary and gives a reflection as to how gradually developing hypoxia is like this. It keeps on decelerating, and when there is absent baseline variability, within 1 hour the baby gets acidotic. And Horn described as Horn step-ladder pattern to death, where it goes up and up with reduction of variability, and then if nothing is done, it comes down. So these can be recognized by computer systems, but there are more problems in addition to what we are just talking about. And this is the paper from New Zealand, Lear's group, and as you could see, the arterial pressure on the extreme left-hand side for you, as it drops, the acidemia starts building up. And as acidemia starts building up, the decelerations get prolonged even after the contraction, suggesting that it starts with the chemoreceptor response on the vessel, but then it becomes a myocardial hypoxia. So prolongation of deceleration is a bad thing. And I'm just giving you an example here. This is some work from Calderobacia talking about auscultation, but I'm taking it for example. So if you take the first deceleration and draw a line between the onset of contraction and the offset, the deceleration will fall into that line. And the next contraction is baby's heart rate is at the baseline, at the surface of the water for a long time. As contraction increases, the deceleration takes longer time to recover. So the depth and duration will increase, and the interdeceleration interval, as you could see, is becoming shorter and shorter. So manually, it's difficult to quantify that. So it will be useful to see the depth and duration of deceleration, rise in the baseline rate, catecholamine surge, reduction in variability, and interdeceleration interval. If all that can be put in together and analyzed, that will be something which is worthwhile. Now, I'm giving you a practical example. This is in our labor ward. The woman was getting decelerations at 1310. They were giving oxytocin without any regards. And as you could see, the baby's deceleration is getting longer to settle down back to the baseline, but the baseline itself is increased. And this is really the straw. If you don't do anything, the baby would collapse because the baseline is coming down. And as you could see, the interdeceleration interval is just a minuscule. So once you stop oxytocin, it recovers and shows the occasional decelerations, and more time at the interdeceleration interval increases, and the baby is born in good condition. So I just think about a baby when I talk about CTG. If you take the baby inside, underwater, but keep the baby on the surface for a longer time, if the baby is not infected or anemic, then the baby will continue. So decelerations coming sporadically or regularly, but at a regular time interval is not something to worry about. Then we have other patterns, saltatory, as you could see here, and that is following an acute hypoxia during second stage labor. If you give epidural, the head jams on the pelvis, reduces the blood flow, and if nothing is done, then it becomes slow with deceleration. They did a section, but it was an early neonatal death. This is with infection, so by adding the clinical data, you can get more information because it's tachycardic with deceleration, so there's some cord compression going because the membrane rupture was 3 days ago. Sinusoidal, again, it can be acute or chronic. If it is like a bleeding, then it will come into place. And this is really cord compression or cord. And you can guess what is happening. These twins, monochorionic twins, and both are okay, and suddenly there is a twin-to-twin transfusion, and the pattern becomes adverse. The question is whether we could have picked some of these before it starts coming. So I'm going to show this one, and unless you have seen this pattern, you can't recognize. Barry, what is that? Cheyne-Stokes, breathing with abruption.
Sorry?
Abruption and Cheyne-Stokes. Yeah. Now, coming back to hypertension, when you treat, and if you drop the blood pressure through peripheral vasodilator drug like hydralazine, the perfusion to the uterus becomes less, and it shows tachycardia and decelerations. And if the blood pressure is high, you have to treat, but you have to deliver. And just a few days ago, I had this trace from Singapore. And as you could see, the first trace seems some deceleration, and continue after that. There seems to be some irregularity, and then suddenly a bradycardia happens. This must be the laser beam. Yeah. So it looks odd, but I thought it was good variability, and then a bradycardia happens. And they did the CSA in 22 minutes from the time of bradycardia, but there was no fetal heart action, and they couldn't deliver. They couldn't have delivered under 22 minutes. It was difficult. But could we have predicted that? Well, looking at the history, what happened, as she has 45 milliliters of blood, fetal blood in the maternal circulation, and the hematocrit in the cord was less than 20. So he had a massive fetal-maternal transfusion. Whether this is anemic or sinusoidal-like pattern, I don't know. I would not have picked it up if somebody would have shown it to me. But I'm just comparing this with Dawes-Redman criteria. Looking at this, I would have not picked up. And this again had anemia, and the machine picks it up. So whether if you would have picked up or suggested something, whether you would have thought a little bit more and acted, I don't know. So I don't know the answer for many of these things. So that is why we have to stress on trying to reduce fetal morbidity and mortality in labor. We need large data set and subject them to analysis of infection, anemia, oxytocics, different gestational age, and so on. So we have to go to deep learning mode, and we can't do that unless we have large data sets. So maybe Antonio can decide on doing number of other hospitals joining and getting large data set. Now, Larry DeVoe, who wrote in this article, The data looking at conventional field monitor has been done. Then we have STAN or ST analysis, and also alerting rules by trace view systems, and that also hasn't given much. And data for the future, how can we inform and get thresholds to intervene? So I looked back at the literature. The infant study had a computerized system which taught algorithm, and it picks up severe decelerations. Now, if the baby has accelerations and then it shows the reduced variability with shallow decelerations, people get worried. But that is due to field breathing, and the author of the paper is Barry. So we can't confuse if it is shallow decelerations after a reactive segment. But if there are no reactive segment, it's of concern that there could be chronic hypoxia. So the taught system can identify a number of things, as I'm showing you, including sinusoidal heart rate pattern. And it can measure the area under the graph, provided it can fix a baseline. And these are the people, and I'm grateful to Philip Steer who gave me the slides. And this also was coordinated from Oxford, the study. And they looked at a number of babies, and the interpartum stillbirth, neonatal death, moderate neonatal asphyxia, or both, whether it's a computer-assisted system or normal visualization with the eye, or both are similar. But the CTG was both similar. Other parameters similar, there's no difference. So the conclusion of the infant study was that we didn't pay much attention to the clinical risk factors. And this was like pyrexia, meconium, duration of labor. So any computerized system must also incorporate clinical features into that, so that it gives an overall picture of how is the baby, rather than looking at odd features in the CTG. And contraction frequency and mechanical issues. And this is from Diago's group in Porto. And that again called the FM alert, including the ST waveform. I think Austin was an author of this paper. And that also didn't show much difference, putting everything together, computerized CTG analysis and the ST analysis. And this is again using a central system in addition to the computerized system. Again, not much of a benefit. So we are going back to machine learning and computer-assisted learning, and that cannot be done unless you have large data sets. And we always compare pilots who are tested 100 times in their career. Obstetricians and midwives are not tested after they qualify. So we are really having a free lunch. So I think we had to come to a stage, not only we had to do computer assisted, like an autopilot who can help the cases, which can be developed by hundreds of cases, putting into the computer, and like a car, which nowadays self-driving cars can be. But the problem with the self-driving car is it has too many sensors and signals. For example, it has 39 sensors and cameras inside the car, 29 cameras outside the car to observe traffic obstacles moving, the LIDAR system, which is actually a layering of the buildings or fire hydrant and so on, and radars to see how far the object is, and ultrasound sensors for reversing side movement and so on. Now, unfortunately, we can't have the luxury of having a motor car like that, because you can't fix all these sensors on a baby's head. So you have to make use of the signals which are available and then put the clinical information. So the Oxford group under Chris Redman has started the work long ago. As you could see here, Antonio has been the first author of many, but you can see from Dawes' time itself, they started about computer analysis in labor. So these are just examples of 4 papers. So the important message here is actually based on each baby counts in the college study of thousands of babies. Is education and training is important, individual human factors, communication, risk recognition. Risk recognition is antenatal as well as intrapartum. And one of the most is oxytocin use, which can cause problems with the baby. So this is how it will look like. There are hardware solutions we have to look at, software solutions, clinical solutions. And The focus points on the CTG is to look at absence of accelerations and cycling, deceleration, depth and duration, and end of contraction, whether it's going beyond, interdeceleration intervals, rise in baseline rate and variability, and reduction and other patterns as well. So vision for future monitoring is can give rise to safer and better targeted obstetric care and reduce unnecessary intervention and reduce the number of missed opportunities of saving the babies. So this is Roberto Romero and his group at the NIH inviting Chris to give an award, and the award was called Giant in Obstetrics Award. But I think we can call him a forward-thinking leader in medicine, because he has led the way to a lot of research in looking after the mother and looking after the baby. And I've illustrated to you with the publications he had done, and also the forethought of collecting data, which will come into good use. And I use the same words like Austin. I didn't talk to him before. Because whenever I had this conversation with him, he says science is measurement. Science is measurement. The second is planning is power. Third is signal processing is the basis. So I would like to thank all of you interested in signal processing, and thank you very much for your kind listening.
Thank you so much. This was absolutely wonderful. I loved the breadth and the CTG cases, and I will review some of them later. It's good I've got your slides. I'm really grateful, honestly.
Thank you.
I will invite a few questions, comments from the audience. Anyone brave? Sue.
That was so lovely to listen to, especially the 36912 rule that's often used but never quoted. You're right, but I will share that knowledge now. I really wanted to know how the definitions of normality evolved with the invention of the CTG, because when I looked at the Dublin trial in 1987, there was no benefit of CTG monitoring in terms of reduction of cerebral palsy. But the definitions of normality for baseline, variability, accelerations, decelerations, the timing of which, all of these have evolved with time. How did the college come up with these definitions?
Yeah, the college looked at, there were a number of literature available even before that. The first time college produces the guidelines was in 2001. I was in the group, David James chaired the group. And we put a big amount saying what variable means, what is late deceleration, early deceleration, and give the pathophysiological explanation behind all this. The subsequent evolutions of the CTG did not give the background material. They just produced only the forward, just the basics of how you interpret it. So it looks like a CTG interpretation on the table, but the first book had all the definitions, and those were from Barry will know. A lot of books were produced in America in the 1980s. So I met Hon and Paul in 1985. He gave me a round table in his office, and I spent a lot of time. And Barry was there, Schifrin was there, Phelan was there. All the stalwarts in the American history were there. So it started evolution. So it's nothing new. I mean, we think we didn't have physiological definition, but we had, except it was in a separate addendum. Austin was going in search of it in the library. I don't know whether he got it on the 2001 edition. But coming to the issue about the Dublin randomized trial, the Dublin randomized trial was, analysis was made on intention to treat rather than treated. So if you look at the paper, initially it says there's no difference between intermittent auscultation and continuous monitoring. But if you go into the depth of it, 20% of the CTG traces were not interpretable in the first stage of labor. 40% in the second stage could not be interpreted. 20% they couldn't monitor, because before they said Jack Robinson, the baby had delivered. But they were all put into CTG, those who had CTG, because the intention was to monitor them. So you can't have an incompletely cooked meal and another which is a different type. Now, if I ask the audience who read the literature and said, now they had fetal blood sampling as an adjunct for this study. So if I say did the women in the intermittent auscultation, did they have a field blood sampling? Anyone who can say yes or no? Maybe they don't know the study. But it was that even with intermittent auscultation, equal number of field blood sampling were done, like the continuous monitoring. So people read the title of the article but don't go into the depth. And the number of field blood sampling in the intermittent auscultation group was the same as in the electronic field monitoring group. And the reason for intermittent auscultation group having field blood sampling, you might say abnormal heart rate, meconium. No, none of it at all. The vast majority were done because they were more than 8 hours in labor. And there were cases of acidosis, pre-acidosis picked up, and they were treated accordingly. So to me, the trial is a big study, but the way it is done, I don't buy it because, and things have moved on, technology, and the midwives, if you ask them who were involved in the trial, they were not given any proper education about how to interpret the traces and so on. So that was also a big draw. So there's a lot of deficiency. I'm not criticizing, but that was the art of play at that stage. So if you remember, 2020, 40 couldn't interpret. Equal number of field blood sampling, and main reason was 8 hours in labor, and they acted on the blood results. Does that answer your question? Yeah, thank you.
Thank you. Other questions, comments? Everyone is hungry by now. We are going to have a lovely lunch at the Battery. Thank you very much again. This was hugely informative.
Thank you.
Thank you.